All right, so like I said before, we're going to talk about moral distress and some of the particular details as it pertains to the COVID-19 pandemic, and then also some strategies for dealing with it. I've got three faculty members today, Dr. Brian Carter, Angie Knackstedt, and Lucia Wocial. In the interest of, we got a lot to get through, so in the interest of time, I'm just going to let the slide serve as their introduction. We've got three major chunks today. First, we're going to talk about kind of what is moral distress and differentiate it from other types of distress. Then next, we're going to talk about moral distress in kind of particular details pertaining to the COVID-19 pandemic. And then finally, we're going to wrap up with strategies for addressing moral distress in the workplace. And first off, we're going to have Dr. Brian Carter. So I'm just going to pass it off to him.
Thank you, Matthew, and welcome to all who are attending across the country and wherever you're from. It's important to the current environment, especially with the pandemic, but throughout healthcare for many years, to define and contend with moral distress. Now, as many of you may be aware, the term moral distress, and this will be the next slide, includes a definition first proposed by Andrew Jameson, a philosopher, and this was first proposed in 1984, so some 30 plus years ago. And we've recognized it, and it's been replete in discourse, in discussions within ethics consults. Academics have addressed it, clinicians have contended with it. And principally it started with Jameson's description in nurses, but in recent years, description in physicians and trainees and surgeons and others have been elaborated. Amid the present COVID-19 pandemic, it's been alluded to in a number of mainstream media reports, some self-reports by caregivers, and has been, again, queried by academics and ethics experts and philosophers. Now, when Jameson first described this in 1984, he stated that moral distress was basically when an individual, and we'll say nurse here because that's how things started, was thought of as knowing what one believes the right thing to do is, that is, making a moral judgment, but being constrained from being able to do so. Next slide will carry this a little bit further. If we think about today, perhaps even where you're working today or have been in recent weeks, how might this be expressed? Well, you may hear a nurse or physician or other clinician express that I feel unable to do the right thing. Now, in this first quote, it appears that the individual clinician, regardless of discipline, has done the hard work of actually figuring out what the right thing is or should be. This person, we can say, is morally aware. This person has also made a moral judgment and feels somewhat morally responsible to act. She's poised to act as a moral agent, but for some reason or another, she is unable. This is precisely what Jameson meant with constraint as being definitional. Now, if this type of assessment goes on and frustration in being able to act continues, it can lead to a degradation of one's sense of self. The sum of all components, physical, cognitive, emotional, and spiritual, they don't feel whole. Their integrity has been breached. As a result, this individual may claim that, hey, this isn't who I am as a person, or in a more collective sense, this isn't who we are as a professional. Now, as a person, it may be a nurse or physician, or quite separately, just as a member of society. And as a professional, alluding to perhaps the profession of nursing, the profession of medicine, or a member of an organization, or even a community, or again, society. Now, some may simply claim, this isn't right. It might be because of lack of PPE, which we've all heard of, extended work hours imposing risks upon their families. Recognizing that this isn't right, however, is only a first step in identifying what might be moral distress. So being overwhelmed is not necessarily the same as being in moral distress. In a similar manner, being tired, uncertain, or genuinely confused, not knowing what to do is not necessarily moral distress. Some circumstances are indeed unique. This is the novel coronavirus pandemic. It's sad, maybe bad, it might be mind-boggling, or it might frankly reflect an ethical dilemma, where action seems necessary, but one must choose from two or more equally compelling choices, and some compromise has to be made. Next. This concept model I borrowed from the reference cited here on the bottom of the page, because I think it adequately explains or illustrates how stressors are present and our responses to them are contributed to by both intrinsic and extrinsic phenomena. That is, factors that we did not desire to occur, this pandemic, this pressure of time to do things, to save lives, to work long hours, to even put family at risk, to endure an economy that has been downturned, and all the health problems associated with it, are uniformly present across many sectors of society, and perhaps not uniformly, but highly representative in frontline healthcare workers. But our balance of distress is met with what behaviors we meet. That is, how are our beliefs, our coping skills, our social support systems, and those things that we've developed habits around over the years rising to balance with this distress? And I think this is what we see is unique across individuals of all disciplines, might be impacted by our cultures, certain other factors, and even medical and nursing trainees. Now, interestingly, in the current pandemic, moral distress has not been something talked about or expressed by respiratory therapists. Respiratory therapists are indeed in their zone, doing what they're trained to do, and are not feeling the tension, or at least it's not been as expressed as much as with nurses and physicians and others. Let's go to another illustration or model. Here I tried to describe or illustrate, again, borrowing from a figure in the reference citation at the bottom of the page, trying to illustrate here what I was speaking about earlier in the language that was used, how people might express what a moral dilemma is. Moral agency lends itself towards action. And when something stands in the way of that action, moral distress is identified. But moral agency just doesn't come all of a sudden. It's composed or contributed to by moral awareness. Some people may not have been typically aware of the confounding things that clinicians deal with on a day-to-day basis, even those that you work with. And then there are other things that we've been painfully made aware of by this pandemic, such as pre-existing injustice, disparate care, social contributions to healthcare, and how they have contributed has been exaggerated, or at least become much more aware by the current pandemic. So when someone sees this, they're morally aware, and they do the hard work of discerning what right action should be, and they feel like they should be morally responsible, they step up as a moral agent. Now, for some clinicians, moral awareness might not be active. Others may not be able to do the hard work of moral judgment. Or perhaps those first two steps have been taken and yet the individual doesn't feel like they have the power, the position to act on this. And so moral responsibility, they believe, belongs to someone else. Nonetheless, these things contribute to moral agency, action, and perhaps constraint with moral distress. The next slide. Now, while Andrew Jameson defined moral distress in terms of knowing what one believes the right thing to do is, but being constrained from doing that, others consider this to be a somewhat narrow definition and might refer to it as only one example of moral distress due to constraint. The philosopher Karina Ferry notes that constraint is not a necessary condition of all moral distress, and that such distress can arise from other morally troubling situations. When health professionals experience distress due to a moral conflict, a dilemma, or they're truly uncertain on how to act, these can continue and contribute to moral distress. They require much more exploration, but nonetheless, they can contribute to moral distress. In these situations, oftentimes an ethics consult can help with unpacking that reality. Next. Now, some have also described moral distress, especially for medical trainees, when students or young residents experience situations in which they may disagree with patient management and feel morally constrained. They don't feel like they're responsible or empowered. They're not sufficiently empowered to take action to change things. So moral distress can exist in 2 or 3 different settings, and the context certainly matters here. Next. Language that's also been bantered about recently have been terms such as moral harm or moral injury. Now, one might ask, if I feel I can't handle this, does that mean I've been morally injured? And while it's been defined, as you see here on the screen, I think that it's been borrowed or perhaps even misappropriated from the psychology and lexicon of behavioral health experts who've cared for soldiers returning from combat. Not all soldiers, mind you, and will not conflate this with PTSD. But as a former U.S. Army medical company commander in the 1991 Persian Gulf War, and someone who has kept in touch with many of our current military veterans from the recent Iraq and Afghanistan wars, I'm familiar with the situations and experiences that are behind them and behind this term. Something egregious has happened. Soldiers who've been sent to battle where they knew that there would be bloodshed and death have themselves witnessed gruesome and inhumane suffering, something that goes against even the rules of warfare, something that is destructive and disrespectful of human life. Perhaps torture or mass killings of civilians, children, or other innocents. It is this breach of a commonly held moral code of humanity writ large, even in the worst settings, that leaves an enduring impact of moral injury. But what most of us know in America and many places where healthcare is practiced in a pluralistic society is that there is a plurality of moral value systems and codes. This may even be evident when at the bedside, when one clinician believes a certain action should be taken because that's what we're here for, while another clinician, while agreeing to the desired end goal, finds and chooses to take a separate path, a different route. A single code or pathway simply isn't always present. Next slide. So moral distress is a problem. And some might ask, if I can identify it, don't I have an obligation to make it better? We've seen, unfortunately, all too real that distress, and moral distress in particular, may be emotionally crushing and contribute to feelings of burnout, helplessness, frustration, depression, and guilt, or even worse, as we have seen healthcare professionals commit suicide in recent weeks. So our next step is to move past these definitional phenomena, and Angie Knackstedt will speak next.
Thank you, Brian. Next slide, please. Right now, as we're experiencing this COVID-19 pandemic, we notice that there's distress everywhere in our world. Is it really distress or is it moral distress? That's what health professionals are trying to decide as we work our way through the uncertainty and the longevity of this situation. So as we look at it, here are some of the things that we're feeling and trying to determine whether it's moral distress or is the distress that we're all feeling as we work through this. So first, the cumulative loss that we're finding. As we hear stories, as we experience these situations in hospitals of the death and the severity of the illness with our patients and families as they come through. The anxiety, even just walking down your street, taking a walk, you can feel the anxiety when you walk past someone being 6 feet to 12 feet apart. And the fear, the look in people's faces when they're feeling like, can I go out? Should I go out? I'm afraid I will get it. But then when also being in their stay-at-home with the stay-at-home orders, you feel the loneliness and the uncertainty of when will I be out and be able to experience. But are all of these, is this actually moral distress or is it distress? I think as we talk, we find this is the distress that we're all feeling. But the grief that comes along with it often makes it even worse because we do have a loss of normalcy. We have some anticipatory grief. What will happen today if I go into work? And then also the lack of control that many of us have when it comes to many of the issues facing us as healthcare professionals. So I think grief is the one feeling that we are all feeling that makes it, that could be in both categories of moral distress and general distress, depending on what the situation is. But when we really look at moral distress for all of the health professionals working in these difficult times, there are these next two bullets will actually come to surface for us. The duty to care, obligation that we all feel as health professionals, the impact that we need to do to make changes personally and professionally to provide the care that our patients and our families need in this very difficult time. But at the same time, are we crossing over? Is our organization helping us to fulfill our duty to care? Sometimes that's where the moral distress occurs. Of course, we've all seen the resource scarcity that we see, most often with PPE. And the moral distress that our health professionals are taking is, what if I don't wear this? What action can I do to protect my patient? How can my organization help me? I need to stand up for what I think is right and to be able to fulfill that and have a policy that helps me do that. What about the visitation policies? We all work with families. Our patients have families. And some of our visitation policies at many places is one visitor at a bedside at a time or no visitors. And what we've seen is how the moral distress that has come upon us with that. I think what happens with moral distress in the situation that we're finding ourselves in right now is really that conflict between the professional and the personal obligations that we have. We're obligated to provide patient care. We're committed to our patients. Our code of ethics is there to back us up with that. But at the same time, we're conflicted because we have an obligation to our families, our own families, to protect them and care for them during this situation. Many of us that are in those situations may be the breadwinner for the family. We need to financially do this. But at the same time, can I do it under the conditions that are currently there? And then possibly, what is the danger to myself when there is a policy that says we won't wear masks at this time until we know we're following CDC guidelines? But would a mask make me feel better that I am protecting not only myself, but the patients I'm caring for? These are some of the issues that we're finding at this time. Next slide, please. Going to go back to Andrew Jameton. Brian gave us a great overview of his work and how the definition of moral distress was started and how it continues. He's continued doing some other work and which is very, very relevant to our times right now. As we remember, he says that the clinician or the professional knows the right thing to do, but is unable to act due to the constraints of either the institution or not being able that they fully or find it nearly impossible to take that action. They are unable to do what they believe is right. Andrew Jameson has begun to look at this in a more global perspective, looking at it from the global perspective of health. And what he's finding is that even now, this quote that he has at the end of his article, What Moral Distress in Nursing History Could Suggest About the Future of Healthcare, he states, we might become even more distressed as we realize that solving ethical problems of healthcare now urgently includes global, social, and environmental advocacy. So what he's saying, it's beyond the individual moral distress that we feel, but will require us to look more broadly. And now the pandemic has hit where we are looking at these issues. So the moral distress has expanded beyond the work from just nursing, but into the all healthcare professionals, as Brian was talking about. But that began about 4 or 5 years ago when we saw that expanded definition where other folks were beginning to do research within their own professionals. So right now, he also is saying that uncertainty goes into the community. As we care for vulnerable people, we can't ignore the systems approach that we need to look at for moral distress, where we need to make sure that we're involved in the system, in the community, for the continuous impact that our healthcare systems need to do, and look at the limitations that it might impact the health of all our citizens. And that's very highlighted in the factors where the risks that we're seeing in our statistics that are coming out of our vulnerable communities of color, where hunger, poverty, illness, and the economic impact is being felt most. And our moral distress as health professional comes for not being able to make the difference, to step up and take the action, but at least we're stepping up as moral agents and being able to bring that out through our words and that hopefully will lead to actions. Next slide. So where are the sources of this moral distress coming at this time? Again, we look to Jameson as he's beginning to expand this, but where there's organizational ethics. Do we work for an ethical, moral organization or institution? Are they looking at the policies and how they impact the workers and the families and patients that we're serving? Are there access processes that are making it so that we don't have to step up and act, where they're actually flowing for the patients and families to get in for the care they need? Over the years, we've seen more and more severity with the diseases that we provide care for. The complexity of this, the rare diseases, the age of viability when our little tiny babies are born. These are all issues that moral distress can cause, because in our belief system, in our values, we see it as one way, and are we providing the care that needs to be done? Is the right action being taken to provide that quality care at the same time not creating moral distress? End-of-life issues have long been the source of moral distress. Oftentimes the futility that we see at bedside staff see as these decisions are made, oftentimes without end-of-life decision making, and that always sometimes doing everything, is that the right thing? And that's where moral distress can occur. Healthcare costs and the increase that we're seeing with new technology and procedures that extend the life of many of ill people. Also, the reimbursement, the moral distress of many organizations, as well as the staff that work for them, the reimbursement for the care that we provide, the lack of safety nets, and also seeing the growing proportion of our GDP in our country being going to healthcare and the moral distress that goes along with that. Now that environmental impact, climate change, we see the change and the impact that's having on health. How do we stand up and give voice to making corrections to those actions or those policies that expand that poverty and other illnesses? Individual autonomy. We, especially in the United States, really covet our individual autonomy to be able to make our own decisions, to do the thing that we feel is right. But what impact is that having on healthcare policies and healthcare processes? Now that the pandemic is here, we see that we need more public health issues, not just individual autonomy. There needs to be the community impact, not just the individual impact. And technology. This is another source of moral distress as new technology comes out, extends the life of patients and families, but also the increase in survival, often what is called the care of the dying. At the end of life, we see more dollars in healthcare costs being spent at the end of the life than we do throughout the lifespan, and the moral distress that incurs. But also the moral distress of having to see a parent who needs to be a caregiver and the person that provides love become a health professional at home. How do we teach them to care for this complex care that their child may need, or the elder person in their life as they live? How can other caregivers of the family, the children, take care of their parent? But there's also, the technology has increased the moral distress for not just patient care, but other non-patient health professionals, and the care and the work that they have to provide, and the use of technology with computers, and now with telemedicine. But looking at EMR documentation, patient portals, how do we work through those issues? The impact on the commitment for the quality provision of care for our patients and families, and how it's impacted leads us into the situation now of the COVID situation and how the changes are occurring, but yet moral distress is there. Next slide, please. So here are some things that we hear day in and day out right now that are causing moral distress, that where our health professionals need to step up, make a moral judgment, and give moral agency to the situation. The constant changes, they've kind of slowed down right now, but the different approaches that different organizations are taking, day-to-day changes, sometimes hour-to-hour changes, as we were getting resources and information from the CDC guidelines, they were changing, and how that impacted on staff trying to keep up, communicating with families, and the moral distress that it caused in making sure that they were following everything that they needed to keep up with those changes. The PPE, this is the one we hear the most, but there were other scarcities. Many of us were working on the backside of, or the back scenes of, looking at how would we triage if there wasn't enough equipment? What if we didn't have enough ventilators? Developing those processes to make those hard decisions, and making sure that as we were making those, that the moral distress that our staff and personnel were experiencing at the time. But also then, lately we've noticed the drugs that are needed to care for patients on ventilators, as well as many other drugs to care for our patients, such as our cancer patients, and not having the scarcity of the drugs that are available to them and the care that's needed. Also, I think we sometimes forget that staffing. These healthcare professionals experiencing the moral distress are also another scarce resource at these times, and what actions can we take for that? We talked about end of life and how it can always be one source of moral distress in our work throughout time, but right now it's the isolation at end of life that is creating the moral distress within the hospital, but not just within the patients and families, but within the healthcare providers that are trying to provide that care to them. Since we don't have a family at the bedside, many of the staff have become the family at the bedside. Also, too often we don't hear the story of the elderly that are isolated in nursing homes, and the staff that are caring for them, and the fear that they have, and the isolation and moral distress that is complicated by them not being able to care for their families at home while they're caring for someone else's family. The standard of care. This is a discussion that at our organization we had a lot of discussion, and you could feel the moral distress in the room of knowing what the right thing is to continue that standard of care, standard of quality care that we always provide, but now is being impacted by the policies and the procedures and just the nature of the care that we have to give because of this pandemic. Kind of a depersonalization of care. You could feel it as we talked about how can we deal with this and how can we help leadership understand what that is doing. It was eating at the integrity of the providers, knowing that we couldn't go in the room. There wasn't as many staff in the room to provide that care. The training that was being lost when our residents and our med students and our nursing students and our respiratory therapy students couldn't be in the room to learn from the situation, from this for the future of the care that they'll provide. But then working with leadership, helping to see how we can make that possible. One of the ways was with palliative care. It's a very hands-on care that we give with palliative care. And unfortunately, coming up with the ways that we could decrease the moral distress of not being able to be there with those discussions by using robots that were usually used in child life to teach kids their schoolwork. We were able to use those to give a face to the patient or the family at home. Having a moral organization and the leadership that gives the transparency that's needed and then needs the recognition and acknowledgement, but also letting the staff know we are with you and here's why we're doing what we're doing in these situations, and we know we're going through as much change as you're going through, but they decrease the moral distress incurred with that. Also, the financial impact. We've talked a lot about that, you hear about that, but it's not only from the individual perspective, but also the institutional that can cause the moral distress in the individuals and the institution as a whole. We are seeing that the cost that is needed for equipment and supplies, with the increasing cost of supplies, how we're able to keep that supplies available, and the moral distress when we don't have it available. But also the loss of funding or the lack of funding. For pediatrics, for example, we were not in the CARES Act. Children's hospitals did not receive the funding that adult hospitals did, and the losses that are incurred with that, with the decrease in patients and the decrease in surgeries, and what impact does that make on staff, and leading to deployment and furloughs. And I think lastly is one of those things is the decreased connectedness that we all feel, not being where we usually are, and how that impacts the way we think and the care that we provide. So addressing moral distress during this time is going to be able to continue what we do best and continue to move forward. But we need to work together to open the moral spaces to have those discussions, to know what the uncertainty is, and to navigate through. Next slide, please. So this is probably the hardest part and where most of the moral distress comes in this COVID situation. For more than 20 years, we have worked as healthcare professionals to make sure that we convince others that the best approach to quality care is family-centered care. The care that we can do when the family is there with the patient and we provide the care to them as a whole, having the commitment not just to the individual patient, but the extended patient, which is the family. It's become our standard of care. But now that COVID-19 has hit, that's been totally upended. What are we supposed to do? What are the families supposed to do? And this quote came from actually a parent on staff that I work with at the hospital, and was said that families we've been talking about that families are the part of the healthcare team, but now again, we're called visitors. And that is the hardest part for them because we've instituted visitation policies. The moral distress that it occurs when a nurse has to tell a family, I'm sorry, there's only one patient, one caregiver that can be at the bedside with our patient at this time. And you can make changes, but not both of you can't be here. There are exceptions to this, but at this time, this is our policy. We do have some remote connection, but it's not the same as being there, especially in the complexity or the times when maybe at end of life. Our communication has changed. How do families communicate? Yes, by phone, yes, by iPad, yes, by the computer, and now telehealth. Learning a new type. How do we build relationships? The moral distress that occurs with that. The decrease in human presence. So we as professionals, as we experience the moral stress, we need to speak up and have the moral agency to work out what are the best ways and the best actions to communicating with patients and families. End of life is too often alone right now, as families are afar and our patients are in isolation. Not knowing the wishes of patients and families at end of life if the advanced planning hasn't been done. Also, the moral distress and the impact on professionals and families when their traditional practices at the end of life are not being able to be done. We talked a little bit about palliative care before I threw it in there, but the closeness of their approach, being able to be there in the presence of families to talk about what the goals of the care will be, and the family participation, as well as initiating those discussions when it's time to make those hard decisions. The moral distress that it occurs with that. And again, with the teaching, being able to learn in a teaching hospital or in a teaching organization to work through that. With the constant change and the constant uncertainty, builds the moral distress that makes it hard for tired health professionals to make a moral judgment and communicate and stand up for those. Next slide, please. Unfortunately, sometimes with moral distress and with pandemic, we find a new situation that we maybe didn't remember was there. So coming from the state of Kansas, I couldn't help but pull on in this slide that actually says we pulled the curtain. We're pulling back a curtain on a very important issue that's been impacting our communities of color and our vulnerable communities for a long time. And that's the inequities and disparities that we see. And nowhere in recent history have we seen it happen as much as we're seeing it in the impact of COVID on those communities. For the percentage of population that we have in cities, we're seeing the highest numbers of the percentages of COVID cases and deaths in our cities within those communities of color. There was a recent article just came out 2 days ago in the New York Times that talked about, we always are talking about resilience and building resilient staff to address moral distress, but it's too hard anymore to address that. We can't just tell people that they need to be resilient, especially the children that need to be resilient. We need to build resilient places for children and families to thrive. So when we look at this, some of the things, Lucia, who you'll hear next, mentioned to me that this is an area that's messy. It is very messy. It's just like making sausage. We actually now see all the ingredients or all the disparities and inequities within the system, and how we know how they've been made over history, overcoming the history and the mistrust that was built over many, many, many years that we now have to do. These communities, and we feel it as we're trying to help them, and the moral distress that we feel with policies and the constraints of policies and federal policies and other policies that have been around, or laws or systems built around this. But there is fear with the patients and families. There is worried and there is mistrust of our healthcare systems. They're afraid to come to us. They're afraid that they will get coronavirus, but they're also afraid, will they receive the care they want? Public transportation. How can I get to the hospital? I'm going to be in contact with so many others. Masks. Unfortunately, in some of our communities, if some folks wear masks, especially young Black men, they will be seen as gangsters. They will be seen as trouble rather than giving, and so there will be mixed perceptions and judgments made on them. Also in our immigrant families, their fear is real, not only of the disease, but of the fear of possible deportation or other things that they have seen in their community that has created barriers to us, and the moral distress that we feel not being able to help them through that fear. But also the basics we've now seen where many are lacking, even just the basics: food, sanitizer, hand sanitizer, masks, and also cleaners, just to keep them safe in their homes. The clinicians are feeling the moral distress because they're coming up against constraints of getting those resources to their families, or the frustrations of their systems and getting them in. In addition, from the pediatric world, again, we're seeing that children, we have many worries, but I also see this as for our elderly who are very susceptible to this disease. There's the worry from immunizations that they're needed, well care, where we need to have that in-person care where we can assess them, especially with young babies and their parents. The impact of the trauma that's going to occur after this situation in isolation, and especially from the developmental perspective of the impacts of social distancing and the care and the teaching that children receive through daycare and other social places for their development. Lastly, the abuse that may be taking place. We're seeing a rise in domestic violence, elderly violence, and child abuse. That is the fear, and one of the things that we are hoping, as we can reopen and have recovery, that we can work through the moral distress and find those system changes that need to occur to help us with all these situations. A quote that came along for me as a pediatric nurse was, "Children are not essential workers or frontline heroes. They're not voters or consumers, but are our collective future." So we need to be able to give them a safe place to live and grow. Next slide. So what does all this mean? We've talked about all these areas where moral distress can occur. What does that mean for us? Well, right now with the uncertainty and the timeline that we don't know. Could there be a second wave? Could there be a third wave if we don't take the actions we need to? What can occur is the crescendo effect that was described by Beth Epstein and Ann Hamrick in their article on moral distress, moral residue, and crescendo effect, is that as we experience this moral distress and are not able to work through mitigate the moral distress through being moral agents and speaking up and being a part of the process, that we will have to live with that moral residue that occurs from COVID-19. We'll need to find ways that we can work through that need to find ways not to live with the moral residue. Unfortunately, I think with the history of pandemic, it will take a while to get through this and we will all feel this. But every time moral residue is present, the next time we experience something, whether it's within this COVID-19 process or in the future, if we have not mitigated the moral distress we felt and the moral residue that is left over, it will be more intense the next time that we experience moral distress. So one of the things that we need to do to move forward is find that balance, then the presence and the compassion and the patience for us to work through this situation to mitigate the moral distress, so that we do not have the intensity of the next time it happens. But also, as Brian ended at the end of his slide, the impacts that we're seeing, the withdrawal that some healthcare professionals are having with not being able to care for their patients in a way that they have always wanted to, with quality care and their compassionate care, but the impact on their own health and the possible leaving of this job or this profession after this situation due to the moral distress and trauma that they're experiencing. So with that, one of the things I want to do is to pass this on to Lucia, to discuss some of the things that we can do to address the moral distress and to see what success might look like at the end of COVID-19.
So thank you, Angie and Brian. I think in listening to all of the potential contributors to moral distress, it's easy to appreciate how people can experience a crescendo of moral distress. There may be disagreements about the exact definition of moral distress, but there is agreement that if we fail to address it, it will have significant consequences for individual healthcare providers, for patients, and for organization. Moral distress comes in part from our heightened sense of responsibility that's directly related to individual patient well-being. During a pandemic, individual patients may not get what we think they deserve, and healthcare providers will always do their best to get them what they need. And during a pandemic, that'll be a challenge. Next slide, please. So when you think about how do we deconstruct moral distress, there are common contributors to the experience of moral distress. Communication challenge is a frequent contributor to the experience of moral distress. Our current communication challenges are too numerous to name. Lack of transparency, hierarchical barriers, having to communicate through video, having masks, all of these things compromise excellent communication. Brian mentioned different perspectives when he talked about clinical opinions. People maybe have a different clinical judgment about what's the right thing to do for an individual patient. Their perspective may be based on what is their professional lens. Maybe the physician sees the patient in one way, a nurse will see the patient differently, a therapist, a family, the patient themselves. Their perspective on what's the right thing to do for a patient may all vary. All of what we know about moral distress hinges on relationships that we've built. We want to believe that we have a direct patient-provider relationship when in fact, all of our relationships with patients and their families are mediated by the employers and organizations in which we work. And that is one of the contributors to our conflicting obligations and sense of responsibility. We have a responsibility to the patient in front of us, and we have responsibilities and obligations to the organizations that employ us. We do know, for example, that physician moral distress is higher if there haven't been conversations with patients and their families about what they would want if things don't go the way that they'd hoped. Next slide, please. For years, we have tried to talk about advanced directives and the power of them and why they're so important. The Center for Practical Bioethics has been championing this idea from the very beginning. While documentation is important, it is far more important to have a conversation about goals, values, and preferences for end-of-life care. when it happens, because it will happen for all of us. That is one thing that has become abundantly clear during this pandemic. There is no one who's been untouched by COVID-19. And one very important, one very unnerving thing about COVID-19 is the uncertainty in prognostication. We do know that if you're sick enough to need care in a healthcare facility, you're at risk of dying. It may be difficult, but the best thing you can do is talk with your family and share what matters most to you. It's a gift to them, and it's essential for the team of people who are caring for you, regardless of where you are. So in the past, we talk about this being advanced care planning, advanced directive, and for some of us now, this may in fact be just in time. Next slide, please. So what are some institutional factors that contribute to moral distress? I think Angie and Brian both have touched on these a little bit. First of all, moral distress is not a character flaw. It is inextricably linked to the environments in which we work. The mission, vision, and values of an organization matter only in how they are operationalized. So for example, the Center for Practical Bioethics provides just-in-time education. This webinar is one example of that, which supports their mission, which is to raise and respond to ethical issues in health and healthcare. Probably nothing more powerful than a global pandemic. Using one of their guiding principles, collaborating with those who are committed to a civil discourse, they've arranged for a collaborative presentation to illustrate the challenges of moral distress. Within organizations are multiple microcultures based on a number of factors, including but not limited to the geography, in other words, a specific nursing unit, a professional affiliation, their physician cultures, nursing cultures, a working group, the shift of people that I work on, day shift versus night shift. We know that resources have to be more than words on a page. They must be credible, they have to be visible, available, and they have to be sanctioned by leaders within organizations. Some organizations don't have resources to have internal resources to support ethical support. And what that means is you may have to look outside an organization for help in resolving issues that are ethically challenging and contribute to moral distress. Professional organizations, even regulatory bodies can be helpful with this. Next slide, please. So how do we look at the individual response to moral distress? What can we do? Self-care is essential. We all in healthcare have to accept that we're vulnerable. And in fact, we're not particularly good at this. The epidemic of physician and nurse suicide in the United States is one painful indicator of this. Self-care, resilience practices are all necessary, but they are not sufficient for how each of us has to address moral distress. We must participate in the ethical reflection on the circumstances that are contributing to the experience. The declaration of a public health emergency has shifted our standard of care. Reflecting on the ethical complexity is an important strategy for navigating moral distress. We know that a top priority is preventing the further spread of disease, which means changing the way that we do things. While we must accept that less has to be good enough, we still can't accept unethical and negligent practices. Next slide, please. If you look at how do we enhance moral agency, it's about acting with intention, not by accident and not by default. Sometimes practical realities get in the way of what professions define as aspirational standards, which can contribute to the sense of moral distress. For example, if you're a nurse, the provisions of the Code of Ethics state that you have an obligation to address concerns about healthcare environments through appropriate channels. And even if those repeated efforts fail, nurses have a duty to resign from organizations when there are sustained patterns of violations of patients' rights and situations that compel nurses to practice in ways that violate their integrity. This is an aspirational standard. However, it is something that contributes to moral distress. We know that the needs of patients may never be used to obligate nurses or any healthcare provider to remain in persistently morally unaccepted environments. By remaining in those environments, we make ourselves vulnerable to the situations and somehow complicit in unethical behavior. Next slide, please. This is a vision of what a moral community could be like. Nobody would jump out of a plane without the help and support of not just a parachute, but those around them for support. Members of a moral community feel free to explore emotionally charged situations, typical when grappling with an ethical dilemma. A moral community is also a place where its members are encouraged to reflect on their practices and engage in deliberation and negotiation about what is the right course of action. Leaders embrace honest mistakes and as opportunities to learn, and a group of people can demonstrate supportive relationships. Next slide, please. So when we think about addressing moral distress in the future state, we have to think about three key things. First of all, each of us must consider our obligation to raise our voice in the face of ethically support practices, knowing that there are real risks to taking action if we report our concerns. We need to do this if we hope to come to a consensus on how we live our shared values beyond words on a page. We now have the what and the why we need to address systematic change, and it will take all of us working together to figure out the how, and that means political engagement and action. A pandemic has shown us very clearly the limits of autonomy, or for example, it's not really all about me. It really is about how do I keep myself from harming others. We have to think about this in terms of not just how I stay safe, but how my actions keep others safe. The pandemic has exposed many cracks and inequities in our healthcare system and society in general. We know that there's a need for meaningful, systematic, and structural change, not just in the healthcare sector, but in all facets of our economy and society. And each of us may feel compelled to right previous wrongs. Next slide, please. As hard as it is, we need to look at this graph, which demonstrates phases when a disaster strikes. It illustrates this sad and difficult reality that we are in a marathon, not a sprint. And this means we have to get it right from the beginning. The stakes are very high in a pandemic, as is true in any ethically challenging situations. There are no easy answers. These are very uncertain times. When we instill a sense of professionalism, we may be setting ourselves up for moral distress because the system is broken. What we all need to do is to look at what is within our power, and self-care is part of that. We need to look to our leaders who offer support to staff and reach out in a proactive way. We have to make clinician wellness a sustained priority, creating environments where reporting options are available as anonymous reporting options so that people can do it without fearing retribution. Mental health resources have to be available to support people in real time, and we have to tolerate the world's imperfection. It's easier to do if you think that it's not entirely your responsibility to fix. Next slide, please. This is a slide that illustrates some resources that we want to make available to you. I know that Matthew in the beginning of the presentation said that there would be resources available. Each of us will also create a resource page with some illustrations and citations from articles that you might find useful. Next slide, please. We want to end with a slide within thanks to our colleagues at the Children's Hospital of Colorado for sharing this very powerful strategies. These are steps that highlight things that each of us can do. First of all, before you end your workday, ask yourself, am I okay? Admit that you might be vulnerable and seek help and support if you need it. Reach out to a colleague and ask, are you okay? And encourage them to get and offer support to them. Always be proud of the work that you do and acknowledge that something you've done may have been difficult and that that's okay. In the end, switch it off because work is for patients and home is for you. Tolerance and forgiveness, I have to go to work and I can't accept doing the best that I can within the resources that I have. I may raise my voice or choose to remain silent because that is all the space that I have for today. I want to thank everyone for listening. I know we don't have a lot of time for questions, but I'm going to take it back to Matthew and see if there are any compelling things that we need to address. Thank you for your time.
All right, thanks all. Yeah, we have a couple minutes for questions, and as just as a reminder, you can submit them via either the chat function or the Q&A function, and we'll get those read out to our panelists. Also gonna see if I can grab John. Looks like we have one here. So, is it possible to consider different levels of thresholds of moral distress, like we sometimes measure risk, depending on the impact of a decision and the principles at stake, or are the inner feelings and are the most important determinants? Thanks for for such an inspiring presentation.
I like to take that.
Go for it.
So I will say there are ways to address or to measure your moral distress. I would say if you rate your own level of moral distress as mild to moderate, then that's something that can possibly be delayed in terms of addressing. But if your moral distress is high, and on a scale of 0 to 10, I would say you're 10, or in my case, I've had times where it was 25 on a scale of 0 to 10, that's something that can't be ignored. And sooner or later, it will come back and it will come out in ways that are unexpected and unpredictable. So when you talk about, are there different levels? Yes, there are levels. And the intensity with which you feel it to some extent will determine how urgently you need to act. I welcome my colleagues addressing that question as well.
Angie, do you want to bring up Ann Hambrick's tool?
I was just going to say, one of the things that I was going to say is there are ways if within your organization that you can assess that by using the moral distress tool that Ann Hamrick and Beth Epstein and their colleagues helped design. But I also think is being sure that within your organization, there are resources for you. There is the ethics committee. There are moral spaces such as at our hospital, the Nursing Ethics Forum, or our unit-based forums that we're having, and moral distress rounds at some organizations. So I think those are ways that is helping our colleagues know what resources are available to them at times of moral distress, and when moral distress increases, that we can reach out, they can reach out to us. But I also think we need to have, during this time of COVID and other high crisis times within our organizations, have our finger on the pulse also in reaching out to those nurses that may be struggling with moral distress and helping them get the resources that they need or be available as a resource to them.
All right, I've got two more questions here, and then I think we're going to have to call it. One is from Connie. It says, thank you for your presentations. Thank you for saying that we should worry about continuing to ask clinicians to be resilient. To me, it places too much burden on them, and what does it mean if they don't have it? Do you think we need healthier organizations, and how do we bridge the divide between administration and clinicians to support clinicians more fully?
Yes, I certainly do think that there is a limit to asking individuals to be resilient if the system in which they work with doesn't change or doesn't facilitate resilience and support them. So I think getting to the closing slide that Lucia had, or excuse me, just it might have been one or two slides before the very end, speaking up, advocating, and seeking policy change are manners in which that can be pursued, and it can be pursued perhaps through your organization's ethics committee or through other individuals. But yes, hammering people with the responsibility to, quote, be resilient without providing the proper environment is unethical.
And I would agree, Brian, that I think that is often the go-to when moral distress is talked about is, well, you need to be moral resilient as an individual, or oftentimes it's probably more that we need to build a more resilient organization that supports the individual in their struggles with moral distress. Because if one person within the organization may be dealing with moral distress, there's probably other times that others are too.
All right, and then one more question. It comes from Blair. It says, use of ethical debriefing sessions when challenges happen helps. So it's more of a comment, but do we want to say anything about ethical debriefing sessions?
I think ethical debriefing sessions can be valuable. Their success, however, might be contingent on the expertise of the facilitator or the individual who's conducting the debrief. Not all clinicians, certainly, and not all members of ethics committees are capable of doing this. And I think we just need to raise that cautionary remark. But yes, debriefs can be very valuable.
I'd like to echo what Brian said. I think much like the slide where I talked about the individual debriefing, you have to acknowledge the emotion that's present with the ethical challenge. But if you fail to address and appreciate the ethical reflection on the complexity of the issues, people will walk away being very unsatisfied and still probably have lingering distress.
And I'd like to add that we have found that I think sometimes if we've dealt with moral distress around certain situations before, that we can use those moral spaces or those debriefs early on as preventative avenues, so that we have another patient maybe that has some of the same things that are happening in a case that is beginning to show. We can use those times to have those debriefs early, begin to talk about how we can work with the plan of care and how we can provide support to the professionals, the caregivers that are going to be going through that situation again. So.
All right, and with that, I think we're going to have to wrap it up. I apologize if we didn't get to your questions, but out of respect to our faculty's time, I think we got to call it. I'd encourage everyone to tune in next week. We'll be talking about, we'll be leaving the clinic and talking about some of the issues related to disparities in the community and the challenges that it poses for kind of response plans to pandemic. Also, just a reminder, these sessions are recorded and we post them to our YouTube channel. So if you ever want to review them or pass them on to colleagues, you can find them there. Just go to YouTube and search for Practical Bioethics. And then finally, I'd encourage you to check out our website. We have a growing set of pandemic resources on a special page. You'll be able to find this and other content there, as well as the webinar schedule and just links out to other resources. So thanks again. Thanks to Brian, Lucia, and Angie, and to everyone tuning in. We will see you next time.
Thank you.
Thank you.